When severe fluid accumulation occurs in the lower extremities, the result is a complete loss of normal anatomical definition. The tissues become heavy, swollen, and distended. That same fluid accumulation manifests internally with equally severe consequences. In the lungs, we see this as hazy white pulmonary infiltrates pooling in the bases, physically obstructing respiratory function. This condition is defined clinically as edema, the pathological presence of excess fluid in body tissues. The majority of this volume pools in the extracellular compartment, the microscopic spaces existing between your cells. Intracellular swelling can occur, typically driven by low sodium levels or a depression in cellular metabolism. However, the massive, visible swelling observed at the bedside is primarily a result of fluid shifting outside the cells. Thousands of liters of fluid cross our capillary beds every single day. A healthy human body manages this constant, massive volume transfer without swelling. Visible edema represents a catastrophic mechanical failure of the physical boundaries that maintain tissue structure. To understand how this boundary fails, we look at the microscopic barrier where plasma leaks from the capillary into the interstitial space. This space is a tightly packed meshwork built of long collagen fiber bundles and a complex web of proteoglycan filaments. In normal human tissue, fluid exists here entirely in a gel state. The proteoglycan filaments physically trap fluid molecules, locking them in place so they cannot flow freely, while still maintaining enough permeability for nutrients to diffuse over to the cells. This gel matrix is a strict biomechanical necessity. If these filaments did not act as physical spacers and flow restrictors, the simple act of standing up would cause gravity to instantly drag massive amounts of fluid from your upper body down into your legs. Normal fluid homeostasis relies completely on this gel matrix maintaining a subatmospheric negative pressure state. The tissue must hold the fluid in place under tension. The body actively fights against fluid accumulation, employing 3 built-in physical safety factors designed to keep that interstitial pressure firmly in the negative range. The first factor is the low compliance of the interstitium. As long as the pressure remains negative, any small addition of fluid volume causes a sharp spike in local hydrostatic pressure, which mechanically opposes any further fluid leaking out of the capillaries. The second factor is the lymphatic buffering system. If fluid does begin to build up, the lymphatic vessels physically dilate and increase their flow rate, pumping up to 50 times normal volume to drain excess fluid back into the bloodstream. The third factor is protein washdown. When increased fluid filters out of the capillaries, it dilutes the proteins already sitting in the tissue spaces. This active dilution drops the local colloid osmotic pressure, effectively shutting off the vacuum force pulling more fluid out of the vessels. These 3 distinct mechanisms operate together as a robust mechanical shield. Clinical swelling only materializes when a systemic disease overpowers all 3 factors simultaneously. This graph charts total interstitial fluid volume against interstitial free fluid pressure, mapping the exact mathematical threshold where the body's safety factors fail. Tracking the normal baseline, the tissue absorbs small pressure increases with very little expansion. The critical inflection point lies exactly at 0 millimeters of mercury. This is the precise moment the interstitial fluid pressure ceases to be negative and turns positive. At this threshold, a violent phase shift occurs. The gel yields, and the volume curve shoots vertically as enormous channels of free fluid expansively accumulate. This mathematical jump into the high-compliance, positive pressure zone is the strict biophysical origin of clinical pitting edema. The tissue structure has physically surrendered. Specific systemic diseases force the pressure curve past that 0 threshold. In cardiovascular failure, a weakened heart muscle fails to clear returning blood volume. Because the heart fails to pump venous blood forward, hydrostatic pressure violently backs up into the venous system and the capillary beds, physically driving fluids straight through the vessel walls and into the interstitium. The resulting drop in forward cardiac output reduces blood flow to the kidneys. The kidneys respond by secreting renin, locking the entire body into a compounding cycle of massive salt and water retention, driving pressures even higher. The tissue is also overwhelmed by physical blockage of the lymphatic system, directly neutralizing the second safety factor and entirely preventing plasma protein clearance. Severe lymphatic obstruction can occur after surgical removal of lymph nodes or from parasitic infections like filarial nematodes, permanently choking the drainage pathways. Whether the pressure backs up from a failing heart or a blocked lymphatic drain, the mechanical result is identical. Fluid and proteins are trapped in the interstitium, forcing the compliance curve directly into the positive range. The final major pathway to crossing the compliance threshold is driven by the critical depletion of plasma proteins from the blood. A severe drop in protein concentration drastically reduces plasma colloid osmotic pressure. Without this inward osmotic pull, the vascular system loses its grip on its own fluid, allowing it to seep into the surrounding tissue. This diagram details renal pathology in nephrotic syndrome, where damaged glomeruli allow massive amounts of necessary protein to leak into the urine. Under the electron microscope, we see the physical damage, fused foot processes and immune deposits destroying the kidney's filtration barrier. This flow chart maps the downstream effects of liver cirrhosis, where failing liver cells stop producing sufficient plasma proteins. Cirrhosis triggers systemic arteriolar dilation and activates the renin-angiotensin-aldosterone system, forcing the kidneys into extreme sodium and water retention, culminating in profound fluid pooling. Whether the necessary proteins are leaked out by damaged kidneys or never manufactured by a scarred liver, the resulting loss of osmotic pull guarantees the interstitial safety factors will be entirely overwhelmed. When the gel matrix is overwhelmed, the microscopic phase shift presents visibly on the human body. We see pitting edema precisely because external physical pressure temporarily displaces the massive pockets of newly formed free fluid through the expanded interstitial channels. This is a structural failure of the extracellular space itself. It is entirely distinct from nonpitting edema, where individual tissue cells swell internally while the surrounding architecture remains intact. This physical model of fluid displacement expands beyond subcutaneous tissue into the body's potential spaces, the pleural, pericardial, peritoneal, and synovial cavities. These anatomical cavities normally maintain a negative pressure state, so the surfaces can slide against each other. This makes them highly susceptible to the exact same capillary leakage dynamics when proteins and fluid escape. When pathological fluid pools in these specific cavities, it is termed effusion. When this massive volume fills the abdominal cavity specifically, the effusion is diagnosed as ascites. The biophysical failure of the interstitial spacer matrix translates identically across all body cavities. A localized collapse of tissue physics manifests as a total systemic crisis. Visible edema serves as the final, inevitable physiological consequence of the interstitial gel losing its strict negative pressure equilibrium. Three distinct mechanical variables dictate this structural failure: a massive increase in capillary hydrostatic pressure, a severe decrease in plasma colloid osmotic pressure, or the physical obstruction of lymphatic return. Consequently, clinical treatment must look past the superficial goal of merely extracting excess water from the patient's body. True resolution requires identifying the specific underlying systemic force: a struggling heart, a failing liver, damaged kidneys, or a blocked lymphatic network, and restoring the physical forces that hold our tissues together.